Great pleasure today to welcome you to NAPCAN's final webinar in the National Child Protection Week series for 2022. My name is Rani Kumar and I am the Head of Policy and Campaigns at NAPCAN. I've been given the responsibility today to guide you through the important conversation about how to create a one-stop shop for families. What does that look like in terms of co-design, evaluation, and sustaining that change? But I'd like to start by acknowledging and paying my respects to the Gadigal people of the Eora Nation, the traditional custodians of the beautiful lands for which I speak to you today. I'm in Sydney. I'd like to pay my respects to elders past, present, and future. I'd also like to pay my respects and acknowledge all of the elders, past, present and future from the lands from which you're joining us today, and to welcome any Aboriginal and Torres Strait Islander colleagues that have joined us today for this discussion. Just a little bit of housekeeping, won't be long, but it's just to remind you that if you're not familiar with GoToWebinars, the control panel's on the right-hand side. If you run into any technical issues, our team has posted their contact details on there, or you can communicate to them via the chat itself. You'll also see in that panel that there's a questions function towards the bottom. Please do keep sending your questions through. We've got hundreds of people online today, which is fantastic, but we do want this to be a dialogue. We want to actually hear from you, see what your concerns are and how our excellent panelists can actually, help tease that out with you. So keep sending those questions through. Relevant handouts and links will also be posted in the chat. So if you need to ask for something, please do. And all the webinars will be recorded. They will be emailed directly to you, anyone who's been registered, but also on our website for any colleagues that you want to share with. So today we're here as part of National Child Protection Week, and even though Child Protection Week is ending, we've still got some fantastic conversation to be had today, and it's my great privilege to be the lead of Child Protection Week at NAPCAN. And every year our aim is to utilise these webinars for fresh and deep conversations about how we create safe and supported communities for children. National Child Protection Week's theme, which I hope you know by now, continues to embrace the overarching message that every child in every community needs a fair go. And these conversations obviously don't end this week. Child Protection Week is just an opportunity to elevate the issue of children's safety and well-being to a wider community discussion. We need to have these conversations about what we as a society need to do to make sure that every child in every community has that opportunity to thrive. But obviously that work goes on year round, and I thank all of you for the contributions that you make. We know at the moment that too many children are not growing up safe and supported, and that child protection systems are overloaded. But there are many opportunities to change the trajectory for these children and their families. We can stop child abuse and neglect and reduce its impact by working together and putting children and young people at the centre of that work. And that's really what today's conversation is about. Exactly how we work together across various service systems, child and mental health, housing, addiction, domestic and family violence, to really meet the needs of families. Hubs exist across Australia, and you may be familiar with the model of co-locating these services so that families don't need to travel too far or navigate complex systems just to access the supports they need. But however, to date, there has been limited research on really how best to design and create these hubs and how to evaluate them and sustain them long term. So today we're going to hear from experts from the Centre for Research Excellence on Childhood Adversity and Mental Health, who sit under the Murdoch Children's Research Institute. They're going to share their learnings from their co-design process, their evaluation and the evidence they've gathered about what families are saying they need, particularly with two case study areas that they can discuss. What are the core elements of an ideal hub? And how social prescribing needs to sit alongside medical prescribing, and what existing hubs and health centres can do to shift towards a more integrated model. So we're really fortunate to have with us today Professor Harriet Hiscock, who is the Associate Director of Research at the Centre for Community Health. We've got Dr. Susie Honisett, who's the Postdoctoral Research Fellow also at the Centre, and Dr. Tess Hall, who's also a Postdoctoral Fellow at the centre. So now I'd like to introduce Professor Harriet Hiscock to kick off the presentation and get us started for the discussion later. Please keep sending your questions through. One thing that I do need to flag is that Harriet is in a hospital setting today, and unfortunately her video isn't cooperating with us. So you'll just be getting Harriet's wonderful voice guiding us through this discussion, but I believe Tess might come on and just be there as the face of the project while and be the next speaker after that. So I'll hand over to Harriet now and come back in at the end for the questions. Please do keep sending your questions through. Thank you.
Thank you so much, Rani, and thank you for your warm welcome. And yes, apologies you can't see my face, but hopefully you can see Tess, and we work all as a really close team. I would like to acknowledge the traditional owners on the lands on which we're meeting today, on behalf of myself and Tess and Susie. We're in Melbourne, so this is the Wurundjeri people of the Kulin Nation. And I think it's really exciting to be able to come and speak to you about our Centre of Research Excellence in Childhood Adversity and Mental Health, which is now in its 4th of 5 years, and it's a project co-funded by Beyond Blue and the National Health and Medical Research Council. But as you'll see from this slide, we've got many partners across Victoria and New South Wales, including partnering with community health centres and with our primary healthcare networks. Next slide, please. So the vision of the CRE is really to create a sustainable service approach co-designed with end users to improve children's mental health by early detection and response to family adversity. And as Rani was saying, there are many hubs, and this one is coming out of a health centre, although we're certainly aware and are working with many hubs that come out of, for example, early childhood settings. So as I said, it's a 5-year project, and we've been working through a very challenging time with COVID, so a lot of it's been done online, which Tess will talk to you about, but to really develop, evaluate and integrate community-based models of health and social care to try and reduce exposure to and effects of childhood adversity in families. And we're focusing on children aged from birth to 8 years, or pregnant mums to 8 years of age, and we're in Wyndham Vale in the west of Victoria and in Marrickville in New South Wales. And we have a fabulous multidisciplinary team of investigators from health, social services and the education sectors. Next slide, please. I probably don't need to talk to this audience about why adversity matters, but there's a fabulous review that came out in Lancet Public Health back in 2017 that really looked at adults who had experienced adversity in their childhood and how that was playing out in adult mental and physical health now. And it won't surprise any of you that if an adult had experienced issues in childhood, they were at greater risk of depression, disruptive behaviour disorders, stress, anxiety, suicidal ideation and substance abuse. Next slide, please. So the aims of the Centre of Research Excellence are really threefold, 3 broad aims. We've completed the first aim, and I'll talk to you in a bit more detail about that. The second aim, Tess will talk about, and the third aim, Susie will talk about. So the first aim was really to understand what do we already know about what works to either prevent or intervene with adverse childhood experiences, and how should the health and social care sectors respond. I'll go to the next slide because I think Susie and Tess will go into 2 and 3 in more detail. So this was really led by Professor Tony Jorm from the University of Melbourne and his team. And they started doing an umbrella review of all the evidence out there of what were the associations between adverse childhood experiences and mental health. And then they went on to look at what the interventions were. What was the evidence of interventions to prevent or ameliorate the impact of these ACEs, or adverse childhood experiences? And then they took this information to a national Delphi expert consensus study to really think about, we've got a lot of evidence of what can work, but what might work in Australia and what might be our priorities for interventions and early intervention. Next slide, please. So this is the results of the umbrella review, and you can scan hopefully on the QR codes, and that will take you straight to our papers. But so the adverse childhood experiences that were most consistently associated with the 4 outcomes that we were interested in, that's depression, anxiety, internalizing problems, and suicidality, The ACEs most consistently associated with child maltreatment, physical abuse, sexual abuse, bullying, and maladaptive parenting. But what really surprised us all was that all of those ACEs had a similar impact on those 4 outcomes. So it wasn't as if child maltreatment was worse than bullying or maladaptive parenting. They all really had similar impacts. And I think that's really important to bear in mind when we're thinking about where to spend our time and effort on intervention and prevention. So the conclusions from that first paper were that given the high prevalence of ACEs in the community and their association with risk of multiple mental disorders and suicidality, preventative interventions targeting ACEs may reduce the substantial burden of mental disorders and suicidality in Australia. But interventions need to be multi-component. They need to focus on improving parenting, economic support to families, providing quality care and education early in life, mental health counselling, and social service referrals. So next slide, please. So the next piece of work that Tony and his team led was a systematic review of what works to reduce ACEs and their impacts on children's mental health. And this was really to provide on-the-ground clinicians, educators, policymakers and families with evidence-based information about which interventions are effective and which are not. And again, you can scan on that to read the paper. And there were 6 areas of interventions that this review identified, and they'll come as no surprise, I think, to all of us working in the field, but it was parenting, community-wide programs, anti-bullying interventions, nurse home visiting, financial support for the family, and specific psychological therapies, particularly for children who had been exposed to trauma. Next slide, please. So that was the evidence, but a lot of the evidence actually comes from the US, and whether it's fit for purpose for an Australian health and social care system was less obvious. So Tony took that information and conducted a national Delphi expert consensus to try and prioritise those interventions for the Australian setting. Next slide, please. And these were the 7 interventions that achieved consensus. And again, you can read that paper, and you can also go to our website to find all our reports and papers. So really coming out on top was parenting programs, which I think is fantastic, but I think we still have a challenge as how do we engage parents in parenting programs, particularly those who might be at most need of it, and is there an issue with stigma of calling them parenting programs, and we can perhaps have a discussion about that. The next was school-based anti-bullying programs, community-wide interventions. The Triple P parenting program came up, and it's been one of the most widely researched in Australia settings, as well as home visiting, psychological therapies for children exposed to ACEs, and psychological therapies full stop. So I'm going to stop now and hand over to Tess, who's going to tell you how we took that evidence and co-designed and are now testing our hub in Wyndham Vale.
Thanks, Harriet, and hello all. I won't just be a nodding head at this point. Next slide, please. So I'm Tess Hall, and I'm presenting on the next phase of our work, which is really the co-design, testing, and some of the evaluation of our child and family hubs. This work is absolutely not just me. It's a part of a huge, amazing team. So kudos to the team just on the screen now. Next slide. I want to start by talking to you though about Jack. Jack is a 7-year-old boy who lives with his grandma, Shirley, and Shirley's been Jack's caregiver since he was a toddler. Jack's mum has struggled with her own mental health for a long time and isn't able to be the primary carer for Jack. Over the years, Jack and Shirley have moved multiple times, and Shirley's found it hard to manage financially. Jack has been having some difficulties moving and settling into his new school. He was sent home from school just this week for hitting another boy in class. So Shirley wants to get help for some of these life challenges that her and Jack are facing, but doesn't know where to start. And Jack and Shirley are not alone. 2/3 of Australian children live with at least one type of financial, parenting, mental health, housing, or legal adversity every day. And today, this is where we kind of come in. I'll talk about the second part of our project, which was the co-design testing and evaluation of child and family hub models to help and respond to families like Jack and Shirley. Our remit is detection and response to adversity for children who are aged from 0 to 8 years old, so from birth to 8 years old, and their families, so taking a family-centred approach. We have 2 hubs in our project. One of them is in Wyndham Vale in Melbourne, which is in the kind of outer west part of Melbourne, and Marrickville, which is in the inner west of Sydney, and brings together a wealth of partners from Murdoch Children's Research Institute, IPC Health, which is our key community service provider partner in Victoria, Sydney Local Health District, as well as local, state, federal government bodies, Beyond Blue, who's one of our co-funders. But today I'm mainly going to focus on our Wyndham Vale site's processes to co-design and test the hub. Next slide, please. So for us, co-design is not a one-off consultation. It's embedded across our whole project lifecycle. Next slide. So from that kind of initiation of the project to planning, through to our implementation and evaluation and the next steps to scale and sustainability. So we see co-design as an ongoing, iterative, often messy, and key knowledge translation strategy for our project. Next slide. So to co-design our hubs, we engaged with 2 different stakeholder groups. Click. The first were families living with adversity to bring their experiential knowledge and recognising the importance of their lived experience to make sure that our hub responds to the needs and preferences of the families who will use the hub. And click. And the second stakeholder group are practitioners from different sectors, so recognising their wealth of practice knowledge from the health, social, community, disability, education sectors. And that's really to make sure that our hub is feasible and supports practitioners to work in an integrated way with each other as well as with families. Next slide. So our Wyndham hub is in the city of Wyndham, which is one of Melbourne's most culturally diverse and growing populations. The IPC Health Wyndham Vale GP Super Clinic was selected as the site of the Wyndham Vale hub because it hosts a range of primary and allied health professionals, social services, including financial counselling. So before we embarked on the kind of active co-design process for the project, we used a number of ways and methods for both understanding and also becoming a part of the service ecosystem that supports families experiencing adversity in Wyndham. So the first part was to do extensive stakeholder engagement and partnership building. So IPC Health, the community service provider, was incredibly important, as well as Wyndham City Council, which is a real kind of leader council in this area, really strong connections to community and all of the different community service providers in Wyndham. So we tapped into the voices and experiences of local families and practitioners through a formative research phase of interviews, online group discussions and observation in the IPC clinic. And so that was really to try and understand the reality of what's happening on the ground in Wyndham for both families as well as the practitioners working with them, and to make sure that we were building on what has already worked, what's already been tried, rather than obviously starting from scratch. So we use this suite of ways for people to participate in our project because we wanted to make sure that we were capturing diverse voices. So from our formative research phase, we found really that families didn't know what services were out there. Practitioners also wanted to have more information about available services. Trust and trusting relationships between practitioners and families, as well as between practitioners themselves, were really important, as well as all of the service barriers that many in this webinar will be very familiar with, the kind of wait lists, lack of services, eligibility criteria for services, really had eroded the trust of families' trust in services in the Wyndham area and presented a big burden on practitioners. So we fed all of these lived and professional experiences into our active co-design process. Next slide. So our co-design process involved these wonderful humans you see on the screen, who worked together to develop the ideas for our hub and then test these out with families and practitioners in the process. So we prioritised lived experience and recruited 2 community members to be part of our core team. They were parents with children aged from birth to 8 years old, and they formed part of that core team with 5 practitioners from different sectors, so health, social, disability, education sectors. And over a 10-week period, the team undertook 7 full-day workshops working together to map out the client journey through the hub, and so contributing in total 35 hours to this project part. Next slide. We used the 5 E's framework of the client journey to guide our co-design of the hub. So often when you talk about service co-design, many projects are focusing on that engagement piece. So what's it like when a parent is in the room? How do we improve the service at that point? But we actually found taking this customer service 5Es framework, which really starts well before that. So how does a family become enticed to come to the hub? How do they find out about the hub? How do they enter the hub? How do we make sure that the hub has a kind of welcoming experience when families arrive there? Engagement. So in this particular context, we were talking about how we could develop a holistic and safe and supportive wellbeing coordinator program, which it works with families to either provide them with connections to other practitioners within the hub, as well as external community-based services using social prescription and care navigation. And we follow this 5Es framework across the 10 weeks of our co-design process. Next slide. So underpinning all of the co-design work was this really design thinking, which is a human-centered, flexible and iterative process that's focused on solutions. And we were really fortunate that IPC Health really embraced design thinking through their innovation and service design program. And so we followed, in each workshop, we followed these kind of empathize, understanding what the needs or families were in each part of that client journey, defining what the key problems and also then what the solutions would flow from those problems. So for example, families don't know that which services are out there, so how might we improve knowledge about available services, for example. Then the team worked to ideate, so come up with as many ideas, brainstorm of, oh, how might we overcome some of those challenges and come up with some different products, and took it a bit further. So then prototyping. So for example, for our wellbeing coordinator, our team came up with a draft flyer of how we might advertise that wellbeing coordinator program or some of the components of it. We also came up with a video that might be shared on a Facebook group to promote the hub. Next slide. The final step of the co-design, or sorry, the design thinking process is really testing. So that's what I think is really unique in our project, is that we didn't just end our co-design process with the ideas of what we thought the hub should be. We actually, through the process, did some testing of these design prototypes with community members and practitioners. So we did this in 2 ways. The first was that each core team member, after the end of each session, tested out the ideas and the prototypes that we developed that week with at least 5 of their family members, colleagues, clients, friends, to really understand, what do you understand this prototype to be? How might we improve it? What would you change? Should it be thrown out entirely? And we also held 2 community conversations to engage the broader community. So one of the community conversations was hosted at the local Manor Lake Shopping Centre in front of Kmart, where there were many, many young families during school holidays. And so again, putting these prototypes in front of people and saying, what do you understand this to be? Would you come to the hub if you saw this? So the other community conversation was at the local Manor Lakes Community Learning Centre. So through this process, we were able to put in front of and reiterate the prototypes with 50 family members, 50 young people. So you can see there's an exercise that we had for our young people to help us to redesign the kind of entry welcoming environment of the hub, and 30 practitioners. Next slide. So what is this Child and Family Hub that we've co-designed? Our hub is made up of 8 key components that are currently being implemented in Wyndham, and I'll paint you a picture. So that family-friendly entry to the hub really means that there's no wrong doors for families to enter the hub. Every practitioner is trained to safely engage families in a conversation about adversity and then provide them with any necessary support or referrals that we have mapped as part of this project. We run Community Connect Days at the hub once a month, which aim to create and strengthen connections with the hub and community members. And these Community Connect Days are run by the Wellbeing Coordinator, whose role is to connect families to those different community supports as well as within the hub using social prescribing and care navigation. We're also providing evidence-based parenting coaching intervention. So this is based on that evidence that Harriet was speaking about, that parenting programs are incredibly effective for supporting families living with adversity. And we're doing this in our project by training hub practitioners to provide light touch parenting support. And finally, co-location is key. So we have a range of health, social, legal services all co-located at the hub. Next slide, please. And this is who's in our hub. So you can see there's a real breadth of services in the hub. So our kind of health practitioners, so GPs, maternal child health nurses, allied health. We've got lawyers who are a key addition to this health hub, as well as financial counsellors. And so where we're up to now, we started testing the hub in April of this year, 2022, and we're focusing on testing for the next year up until March 2023. And so the key focus up until this point has been to really strengthen connections between our practitioners in the hub. And the next stage is to really strengthen those external connections to, as you can see, early childhood centres sitting outside, community centres, maternity hospitals, etc. Next slide. So now I'll talk you through some of our key take-homes from the co-design and testing process to date. So trust has been crucial and so important across all stages of our project. So from that initial trust building with community members and stakeholders during our partnership building phase, trust also came out as a key barrier to families accessing services, which meant that we then focused our co-design process on how we might build trust within the hub. And during implementation, trust has also been really important and focused on through our training and capacity building with practitioners so that they are able to engage families in a way that is going to build trust and not alienate families. Next slide. Team forming and building. So we wanted to make sure that we got the right people in the room for our co-design of the hub, which meant that we paid our community members and we back paid some of our practitioners in order to recognise their time and expertise in the process. We also took care to engage with a range of people with different experiences, knowledge of Wyndham and Wyndham services, and an openness to learn. And as I said before, really embrace the messy, because there's a lot of grey in co-design, and that's kind of what you want. You want diversity, which means difference in opinion. In terms of our implementation, team forming has come through having our monthly meetings with practitioners. So there's been some really important relational processes of people meeting and greeting each other, norming and storming how they're all going to work together, these practitioners in the hub, as well as regular check-ins from our team working with the IPC project managers to make sure the ball is rolling, particularly in these COVID times. Next slide. There's been a real power and beauty of bringing our community members and practitioners together in the core co-design team, which is carried on through our implementation phase. So really allowing that mutual learning through diverse perspectives. So some of our practitioners said that being part of the team with families with lived experience really helped them to understand families more and actually change some of their practices. And our community members said, actually, it was really interesting for me to understand some of the constraints that practitioners are under in the service system, to have more of an understanding of why particular service experiences might have happened to them in the past. In terms of implementation, we've been able to embed community voice in our monthly learning collaborative meetings with practitioners. So we have a peer researcher with lived experience as part of our team, who is part of the learning collaboratives, and it kind of has a transformative effect sitting in that group of practitioners, able to respond to any kind of concerns about, oh, do families actually want to be asked, how might that land? We also have plans through our process evaluation, which I'll speak to in a minute, to make sure that we're capturing the family's perspective on how the roll out of the hub has been. Next slide. Another key learning for us was really to meet people where they are, both figuratively and literally. So we were initially thinking about doing our user testing in the hub itself, but out of our first co-design session, all of the members were like, nah, you need to go to Kmart. That's where the families are. When also, as I mentioned before, really offering multiple ways for people to engage. If you're wanting to capture diverse voices, people will have different preferences and abilities to engage with the process if you offer those different avenues. From an implementation perspective, we're making sure that we're kind of after the co-design, really offering different online offerings to participate in our kind of collaborative exercises for our practitioners, again, to make sure that we're meeting people where they are in this COVID environment. Next slide. So it has been a juggling act of competing priorities. So time and resourcing is a huge challenge to many kind of collaborative co-design processes. So on the one hand, we had a huge amount of work accomplished in a short time during our co-design and during our testing, but it's also been a huge commitment. You know, we've resourced facilitators, myself and one of the IPC members, Sandy Pullen, to plan, conduct and do the sessions. Our core team members on the co-design spent a lot of time, you know, 35 hours in your week over 10 weeks is a long session. In terms of implementation, it's been really important to kind of iterate and flow with the different shifting priorities with all these different pandemic waves that we've had. So we've had staff shortages, so making sure that we're responding to those priorities and not adding extra pressure to people at this time. The next slide is a video that I'd like to show that really rounds off our talk about co-design and testing before I talk briefly about evaluation. So bringing the voice of Michelle, who is one of our community members in the co-design process, to really also hold us to account publicly in this forum. Next slide, please.
My hopes for this project going forward is that the powers that be actually do implement the things that we created. We spent a lot of time, energy, effort into building, refining, testing, reiterating our designs of what would really benefit our community. I really do think that what we have ended up creating is what the community needs.
Thank you. And so just quickly on our next phase of the project, which we're undertaking at the moment, is a mixed methods process and evaluation, outcomes evaluation. And for those who aren't researchers or evaluation nuts in the room, the reason that you do a process evaluation is so that you make sure you're capturing all of the activities that happen while you're testing out the hub, so that if at the end we don't necessarily see any changes in outcomes, we understand why. Or hopefully, if we do see some improvements in time in our key outcomes, we also understand why those improvements have come to be. So we've collected our baseline data collection. We're undertaking our process data collection alongside the hub testing, and through that we're doing what are called plan, do, study, act cycles, which are improvement cycles. So again, not seeing our co-designed hub model as set in stone, but really making sure that we're checking in over the course of our hub testing, reiterating as needed, and then collecting our outcomes both from the family perspective and our practitioner perspective at 6 and 12 months after our baseline data collection. Next slide. So in terms of our key focus for the evaluation, we're really wanting to understand our hub practitioners asking about adversity, and we do this through family report as well as practitioner report, and then our hub practitioners responding to adversity. So looking in terms of what type of direct supports or referrals have been provided, and as well as what the impact of those supports have been on child and caregiver mental health, quality of life, parenting, using validated measures. We also have 3 other key focuses within our hub, recognizing that there's a lot of moving parts, wanting to really unpack more about our wellbeing coordinator. So we have a nested evaluation around the wellbeing coordinator, that legal support, again, recognizing that placing a lawyer in a health setting is a really interesting and relatively emerging field. So wanting to understand more about how that's working in our Wyndham Vale site. And then integration, so wanting to understand what those linkages are between our practitioners and whether they change over time. Next slide. Lots of talk from me. I'll leave you with this. This is some of our baseline data, which looks at the life challenges or adversities experienced by our families in Wyndham. And I guess it's to say that there are, 72% of our families at baseline said that they were experiencing one or more challenges outside their home in terms of lack of social support, money, housing. 78% said that they were experiencing at least one or more challenges inside the home, including caregiver mental health challenges, conflict between family members, family violence, and 25% of our families in Wyndham said that they were having other broader kind of legal challenges in terms of visa and immigration issues, discrimination. So there's an enormous amount of work to be done, and a lot of people who are not necessarily reaching the supports at this point. As you can see in the bottom half of our tables there, we only had 14, 17, and 5% of families being asked about any of those challenges at baseline. So what we're hoping it happens over this next 12 months of our testing of the Child and Family Hub is that we'll see that there'll be improvements in the identification and response rates to families experiencing those different challenges because of all of those other activities that we're doing, include in terms of supporting our practitioners to work better together in an integrated way and engage families more and actually know what supports are out there. So thank you very much. I'll hand now to Susie Honisett, who'll talk to you about scale and sustainability.
Thanks, Tess, for that great overview of the co-design and showing all of you what the hub actually is and what we hope to achieve. I wanted to talk a little bit today about scaling and sustaining this hub model that we've been working on in Wyndham Vale and Marrickville. And the reason that this is an important issue really is that we could get to the end of our funding period and find that at the end of that time that the hub perhaps falls over, or we only get as far as those two sites, Wyndham Vale and Marrickville, having hubs implemented. Next slide, please. By focusing on scaling and sustaining hubs, what we hope to do is expand the use of this evidence-based intervention, that being a child and family hub, to a larger area so that we can increase the public health impact of these interventions. And in this case, having more families and children supported. Starting with our original site on the map on the right-hand side of Victoria, we've got Wyndham Vale in the blue. What we're aiming to do is scale or extend this model to other areas, including areas that are experiencing greater need, Monash and Bendigo, as well as Brimbank, Melton, Whittlesea, Heidelberg, and right up the top with Sunraysia, which is in Mildura. However, scaling is not just simply a process of spreading this exact model of what Tess has just spoken to you about of our hub to other places. It really involves a complex interaction of the hub model itself with local contextual issues and the local environment in which that hub will be embedded. And really, to do this well, we need to create a learning culture in the organisations that we're working with to scale and extend hubs in other areas to ensure that those core or necessary components of a hub are being implemented and, most importantly, adapted to suit the local context. And they're also regularly monitored and refined to ensure the best outcomes and fit for that local area. So this is not about being true to the original fidelity of the hub, but making sure that we do have adaptations that are based on local context. Next slide, please. In advancing large-scale systems change and amplifying the potential impacts of hubs, we consider scaling using three different terms: scaling up, scaling out, and scaling deep. So scaling up really refers to changing institutions at the level of policies, rules, and laws. Scaling out is really related to replication and dissemination of the hub. You can see we've got our blue Marrickville and Wyndham Vale hub, and we want to have this model in quite a number of other sites to really extend that population health outcome. Again, adapting those as need be to those local contexts. And then scaling deep really relates to changing relationships, cultural values and beliefs to impact cultural roots of change and ideally sustain these interventions within organisations. So for example, when we leave and this project funding is finished, we have organisations that see the hub as routine practice and just the way that they work. So scaling up, scaling out and scaling deep are all important processes to scaling hubs in a real world setting and sustaining these changes beyond the end of our funding period. Next slide, please. But before we attempt to scale, we need to know what are some of the barriers and enablers to do this. And to better understand those, we undertook some evidence gathering, and I've just listed some of those evidence gathering strategies that we used here. We undertook a systematic review that looked at the effects of integrated health and social care hubs on children's mental health outcomes, and you can see that paper through the QR code there. We also undertook interviews with policymakers and hub implementers, so those managers and CEOs in community health services, to really assess whether the hub model was feasible in their local area or broadly across Victoria, and to get their opinion in what would be needed to scale and sustain these hubs in other areas. And finally, we did a policy scoping of state, so in Victoria and New South Wales, as well as federal policies, to really understand the breadth of policies that interacted and intersected with adversity. And we found over 188 policies through this policy scoping, and then prioritise those down to really look at those that would support the work of the hub in other areas. Next slide, please. And this slide shows the outcomes of our evidence gathering. We can see from the top, the positives or the enablers were that community health services already engaged really well and had great relationships with vulnerable communities in their areas. They also had really strong service provider networks beyond the community health services themselves, but into other social and other organisations in the local area. There was definitely a readiness to act on the issue, and more broadly, in a systematic level, there was a supportive policy environment with many state and national policies focused on adversity. However, there were some barriers, and those included insufficient or inflexible funding models. For example, GPs and other allied health staff being funded for fee-for-service funding models, which really inhibited their ability to coordinate work across other health professionals and other social organisations to provide an integrated or family-centred approach to care. There was also an inability to fund community paediatricians, which we see as really a clinical lead for hubs, providing a great deal of support and capacity building around child development, and some inadequacies in terms of workforce competencies. However, overall, the hub model was seen as feasible and was supported by the stakeholders that we interviewed. They would like to see, however, local co-design happen with each new site, co-location, and the potential for virtual delivery in some sites, particularly in rural and regional areas, to really support implementation. More broadly, again, at a systematic level, we need clear leadership, reviews of current workforce and funding models, and ensuring that local co-design and leadership are supported. But overall, there's good evidence for implementing hubs more broadly. However, some key systematic barriers. Next slide, please. The results of this evidence gathering were then taken to our reference group, our knowledge translation reference group, which involved researchers, policymakers, hub implementers, and our peer researcher, who Tess mentioned earlier on, who has lived experience of adversity. And we used this evidence to really brainstorm strategies and prioritise those to support scaling and sustaining of hubs. Next slide, please. These are the three key strategies that were chosen by our reference group for scaling hubs, and I'll talk a little bit more about these in a bit more detail. Next slide, please. The first one being government knowledge brokering, and this is really a key strategy for scaling up and really influencing policies, laws that brought a systematic approach to scaling. You can see here we've got three sub-strategies there, looking at how we might define hubs. What are those core components and necessary components that will be required when we scale to each new site? And there may be other components that perhaps are less important, or that maybe community health services may be able to add at a later stage as they build their capacity. We're also surveying hubs to understand what is the current workforce mix within those hubs and what is their ideal workforce mix, and what is creating that difference between their current workforce mix and their ideal workforce mix, to really understand what is the workforce competencies and capabilities that will be required in hubs as we scale them to other sites. And finally, we're working with our health economists to do a review of funding models in primary care to really understand what might be the best funding model or mix of funding models to support coordinated and integrated care across health and social care. Next slide, please. Actually, not finally, the next strategy is our National Child and Family Hubs network. And this is a key strategy for scaling up and also scaling out. This group represents hubs across a range of settings, including early childhood services, primary schools, community health, and other non-government settings as well, and represents around 100 hubs nationally. The aim of the network really is to accelerate learning, to ensure that we consider what are the common elements and the core elements of hubs across these settings, and how we might, as a network, work to sustain and embed this work in states and territories. There's lots of evidence that's being generated through research projects that are represented on this network, and what we hope to do is gather that evidence and be able to disseminate that to other hubs so they're not starting from the beginning, but they can utilise that existing evidence to really support their development and growth of hubs in other areas. Next slide, please. The final strategy is a child and family hubs community of practice. And we'll start in Victoria with 3 hubs that are being funded by the Department of Health. This is under the Victorian Royal Commission. There was recommendations for hubs, and this is a promise that the government are standing by, and they're funding 3 additional hubs. I mentioned where they were Bendigo, Monash, and Brimbank Melton around Victoria, and we'll also add in some other hubs that we're working with, including Sunraysia Community Health Service and DPV Community Health Service, and our original site in Wyndham Vale as well. The aim of the community of practice is really to be able to provide this network and reflective practice for those that are implementing hubs across a variety of different sites, to be able to learn from each other and support each other through that process, and come up with ways to adapt this hub model within their local context. We're also applying for funding for a national community project to support hubs in other states and settings as well. So we're working primarily in community health services here in Victoria. However, as I mentioned, there's lots of other hubs that are happening in other settings such as early childhood and primary schools, and it may be appropriate to have a community of practice for each of those. Next slide, please. I wanted to end on the following note, and that is that we've spoken a lot about physical hubs today and the development of evidence around those physical hubs, but we're also in the process of developing a virtual child and family e-hub. The aim of the e-hub is to increase access and engagement with existing services by providing an online navigation to relevant evidence-based resources and information and services for families. We're currently working with a digital health organisation to develop the e-hub, and have been interviewing families and local service providers in 3 sites, Wyndham Vale again, and 2 sites in New South Wales, Marrickville and Fairfield. And through these interviews, we hope to really understand families, caregivers' needs, in particular their pain points in accessing information and navigating services. Over the next year and a half, we'll be developing the minimum viable product for this e-hub and testing and evaluating that in those 3 sites that I mentioned, so stay tuned. But finally, thank you very much to NAPCAM today for having us on board, and really enjoyed presenting here today, and looking forward to answering any questions. Thanks so much.
Thanks so much, Susie and Tess and Harriet. I hope you're still there, Harriet, on the audio. That was a really great presentation, and so much to take home from that for services across the community. And I really look forward to hearing more as the evaluations come through at those different points. We've had some really good questions come through, so I might just go straight to them to make sure that we have enough time to get through as many as we can. I guess one of the questions is really looking at, someone from the audience is saying they're interested to find out how services overcome the barriers to working as a multidisciplinary team. This person works in a maternal child health team, but is not a nurse and seems to kind of sit outside the team, as does the social worker. Like, so have you encountered these issues, and how have you kind of tried to encourage that, collaboration between the practitioners?
Rani, it's Harriet. Can you hear me? I'll take this one, and then let Susie and Tess step in. Look, it takes time, and you need champions at the level of the practitioners and the level of the managers as well. I guess what we have had to do, and it's been quite tricky during COVID, is create a shared vision, because if you don't have a shared vision about what you're working towards, then people won't get on board. And then within that shared vision, you need to understand what is the role of everyone in the team. And just co-location doesn't mean integrated care. You've got to do much more than just all sitting in the same building together. So I guess what's worked for us is bringing on board the management level of all those different practitioners that we have in the hub, and that's several organisations, trying to create a shared vision that they all understand and can all see they have a place in. And then we're doing the very old-fashioned thing of lunchtime learning collaboratives, where we provide them with food and lunch and bring them along so they get to know each other, and they're starting to trust each other. And that within those we do sort of discussions of families and how to ask about and respond to adversity. And the different players in that room are now starting to see, oh, this is what a nurse can bring, or this is what a lawyer can bring, or this is what someone else can bring. And there's a recognition now that's growing that everyone has different skills that they can bring support a family with. But it takes time, and you have to have an authorising environment and a shared vision. And food always helps.
Did you want to add anything, Tess or Susie, to that?
Sounds good.
No? I would just ask about these learning lunchtimes. How are you finding they're working? Are they, was it slow to start to get people to come and give up their lunchtime, so to speak, to kind of with others from the, same hub? Like, what's it looking like in practice?
Yeah, look, it's taken a lot of work by our colleagues on the ground at the hubs. It's been particularly challenging, I think, for the GPs, which Tess alluded to. They are not salaried, they are bulk billing, so time is money. So actually IPC Health is paying the GPs to come to the hubs. The other practitioners are salaried and see this as important, but we have to book out people's diaries ahead of time, go around knocking doors, remind them to come along, get food. And so the first 2 or 3 months has been pretty challenging, but now I think they're going because they get something out of it. And we do bring along speakers from different where we feel that's relevant. We talk about, perinatal mental health, for example, or whatever might be the topic they want. So I think once the practitioners see there's something in it for them and it's helpful to how they look after families, then they will start to come. But if you just go there and it's just a chat fest, they're probably going to stop turning up.
Yep. Fantastic. Great. Great to hear that it is a bit of a journey for people out there who might be trying to set sort of, these lunchtime learning things up. And you can see there's a bit of enticing, similar to the families, to the practitioners to kind of get to know each other. But, fantastic to hear that it's, starting to reap that benefit and the networking across. I guess just to pick up on something you said there, Harriet, about the funding and the bulk billing for the GPs, etc. Susie, you also mentioned that you were looking at the funding models and what are the best ways to fund these sorts of hubs. In terms of sustainability, I guess, IPC can't keep paying the GPs long term, perhaps. So what would that look like? Any comments on what, you think funding models for hubs should be, or or is there a kind of way of, Looking at ideal models to start off, and then what happens with that sustainability? Happy
Susie? I'll throw to Susie.
Okay. Yeah, I'm happy to start. Certainly, I think the fee-for-service models really are an important approach. However, I guess what we're finding is that a fee-for-service model really promotes this seeing lots of people. So GPs are paid by the number of people who are coming through the door. So a 7-minute consult really is really tricky to really get down to some of those difficult discussions that we need to start having, and those relationships that you need to feel like you have, and the trust to be able to draw out some of those difficult issues that families might be facing. So we know that other funding models actually incorporate an ability to work with other professionals more clearly and be able to work across a range of health professionals, and that's actually incorporated into the payment structure. So it's not just a quick flow through of, as opposed to fee for service, but it allows that coordination across other health and social services as well. So it's about finding the right mix, I suppose, of funding models. I don't think fee for service will ever go away, but it's about thinking about that fee for service and perhaps capitation or other funding models that support that more broader coordination of work across a broader range of health and social professionals.
Mm-hmm. Thank you. Harriet or Tess, did you want to add to that at all? No?
I'll just add to this that this is incredibly frustrating for the people running the hubs. They have to get their money from all sorts of different sources. It takes a lot of time and resources. And as Susie was saying, I think we need to look at a coordinated approach. We're looking in the literature for evidence. There's very little evidence about the ideal funding model. I guess they're hard studies to do, but you know, the federal government, certainly from a health point of view, is looking towards people having to be signed up for general practice, a bit like they do in the UK, and having a sort of healthcare home for families. And I think maybe that's a first step towards that sort of blocks of money being given them, for example, to hubs to say, here's the people who live in your area, here's X amount of dollars to look after them each year. You decide how best to use that money to service your population. I mean, that's nirvana for me, but maybe we can start to work towards that.
Yeah. No, great to hear about other, international best practice as well, and what else we can look at. There's a few questions coming through about, how universal the hub is in terms of families accessing the hub. Is it, are you getting a lot of people who are already in contact with the child protection system, and has that impacted the engagement of families? Because we know often, it's a motivation of families, why they're there. Sometimes if they've, sort of court or child protection referrals, it can be a different kind of energy that, the practitioners are getting and the families are bringing to the engagement. And is it kind of looking at that sort of, early intervention and prevention side? Is it universal? Can any families access these hubs? So maybe Tess?
Sure. So I think a really interesting contextual element that I probably didn't draw out in our Wyndham Hub is that most families who attend the Wyndham Hub are seeing the GPs or the paediatricians, like the vast majority. So there's also maternal child health services and those other kind of allied health social services sitting around them. But that does actually mean that we are seeing a really broad mix of the population in Wyndham based on our baseline surveys. So based on our baseline surveys, we had approximately 70% of our families were born outside of Australia, or spoke a language other than English as their main language at home. So that tells us that we're at least capturing the demographic of people in Wyndham, which is a really diverse area, as I mentioned. In terms of contact with the child protection agencies in particular, that's not a question that we asked. We were asking more about general health services, but we did, as I mentioned, we did find that people were saying, well, that was also another quirk I didn't go into detail about, but in terms of our baseline data collection, we decided we didn't want to rattle off a whole list of negative experiences that people would potentially not feel comfortable disclosing, but also potentially perpetuate service failure. If they'd experienced before that they'd spoken about all these things with people that they were provided support with, we didn't want our research process to effectively do that again. So the way that we asked about adversities in our baseline, and we'll repeat this at 6 and 12 months, was we classified our adversities into 3 different types of domains. So that inside the family, outside the family, and social or legal needs. And then we had our families listen to the list or read the list if it was online, and then elect how many of those adversities in the list. So not needing to disclose, I've experienced family violence, I've experienced mental health challenges myself as a parent, but we got an understanding of, I guess, the burden or the severity of their experiences without having them to disclose unnecessarily, because from an evaluation perspective, we wouldn't need that level of information to understand any change. So probably didn't necessarily answer your question about the child protection contact, but I would say that we are seeing a universal range of families at Wyndham.
Yeah, I think I'll add to that, Tess. I think one of the things that the families have told us is they like walking into the hub because it's non-stigmatising. They're not walking through an orange door. And when they walk through the hub, they could be seeing the GP, the paediatrician, the maternal child health nurse, or the financial counsellor, or a lawyer for family violence reasons, but no one knows why. So I think health and education are really great platforms for hubs because they're not stigmatising.
Yep. Fantastic. Can I just ask on that, how did you decide on the mix of the services that are located there? Was that part of that sort of localised needs? You know, for example, the financial counselling and the lawyer being present in this hub. How did you kind of identify those needs?
We brought them in, Rani. So we really, from looking at the Theme A work, which talked about the huge range of adverse childhood experiences that children and families in Australia are experiencing, with financial difficulties, housing difficulties, job insecurity, rental problems, family violence. And I had to go to a conference from Health Justice Australia the year before, who are a fabulous organisation who broker relationships between health and justice settings, and I spoke with them. I said we'd love to put a lawyer in the hub, and so we've managed to do that in both sites with their support. And we're not paying for the lawyer. The on the ground legal systems in those two states are paying for the lawyers, so that's, you know, potentially an enduring, you know, sustainable approach. We're trying not to pay for any additional practitioners have come to the hub, because we think it's really the role for the organisation to pay for them. And we have had some state government funding for the social prescribing role. So they're all new to the hub: the lawyer, the financial counsellor, and the social prescriber / wellbeing coordinator roles.
Fantastic. No, I was really interested to hear was that coming from the evidence, and how to, you know, bring some services that families might not themselves think that they need necessarily, but if they're there and you can have those conversations, it makes it so much easier to connect.
Yeah. We've had to train the health practitioners to recognise legal issues as well in families and what questions to ask.
Yeah, and because we know that those burdens on families, you know, it adds that stress. It's like that, you know, the cumulative stress of different things coming together that they might not know, and they're coming to the GP for a different issue, but really it's about the finances and not being able to, you know, get on top of those things. So great to hear how you've kind of mapped that out. Harriet, you used a term there that I think our audience would like explained a little bit more, which is social prescribing. What is social prescribing?
Yeah, and Tess and Susie, feel free to hop in. Look, it's really something that's growing, particularly out of the United Kingdom. And it's a role where you have someone who connects clients to existing services in the community. So it really started in the UK in older adults who were socially isolated or lonely, and it looked at connecting them into existing things, which might be a cooking class, a yoga class, an English language class, etc. So there's some evidence for it improving loneliness and social isolation in older adults. Very little evidence of if it's helpful in families, but we're trialling that at both our sites. It's tricky because it sort of blends into a care navigator role as well, because the system is so difficult for families to navigate. But we're hoping we can also have that element of joining up young mums to existing community programs to help them with their self-efficacy and potentially their loneliness and social isolation. Don't know, Tess or Susie, if you wanted to add.
Yeah, no, I think absolutely, Harriet. The only thing I'd add is just social prescribing recognises the social determinants of health. So as you mentioned earlier, Rani, that someone might be for a particular health issue, but actually if you can link them to an employment agency, that might really bolster their mental health in ways that counselling may not be able to, or combined with counselling. The other thing that I think is really crucial is that through our co-design process, our families were really loving the idea that there would be someone who wasn't necessarily, for example, seeing a paediatrician. They wanted to see the paediatrician for a particular reason for their child's needs, but having a practitioner who would actually be able to have that more holistic assessment, so that they weren't needing to use their time with a paediatrician to talk about some of those broader adversities. They actually felt like having that carved out space was something that would be of benefit.
Fantastic. Susie, did you want to say anything else about that?
No, I think it's been covered beautifully. There's nothing more that I can add that will round that out.
I do love the idea of it as well, that whole sense of, building those stronger communities and things that are already existing and linking families in. It's not always a sort of, a particular service in a structured sense that families need. Sometimes it's connections that are more informal that really, can assist in raising children well. Have you all heard about the park run? I love the park run idea, which is one of those social prescribing things that GPs apparently have started doing. And it's just, people getting together in a park, and it's you don't have to be very fit or whatever to do it, but it has been one of those things that is coming up more, I think, in the conversation broadly. How do we create these communities that can actually support people outside of formalised, services? So great to hear more about that. I guess one of the questions that links to what we've been discussing just now is this whole, no wrong door. It's a place that families can come to, and you've got such a broad mix of families who are coming, which is great. But what happens to those families who are outside of that, I guess the cohort that you're targeting or are accessing, the 0 to 8? So anyone who's got older children, or, the services might not fit. I'm sure you've got great referral services, but just to kind of get a sense of how that might work for those families.
Tess, did you want to respond, or did you want?
Yeah, or you, Harriet. I guess I'd just say that because this is a research project and we're really trying to test out the idea of the hub, in the first instance, that is our kind of catchment and our cohort, children who are aged from 0 to 8 years old. Having said that, many families in our cohort have multiple children. So if there was a child who was in that cohort, but there were other siblings who were older, they would still be kind of in our remit of service. Harriet, did you want to add?
No, I think that's right, Tess. And, why did we do 0 to 8? Well, it was really, about the evidence that says getting in early in life, early in the course of any issues, what we were focusing on. We were trying to go up to 8 because there's a slightly strange situation in Victoria. I don't know about the other states, but a lot of the services cut off at school age, and then you're supposed to get all your help and support through the schools, and the schools are just overwhelmed. So we were by a bit of stealth trying to get our state government to think about, beyond 5 and not having that as such a hard cut-off for community health services, and extending that to 8 because of that. But as Tess said, we're just, I guess we've got to walk before we run, but there's no reason why this sort of approach couldn't work for families with older children, and certainly the councils we're working with do have a lot of youth support services that younger, older people, but young adults can be referred to as well.
Yeah. And I think, as Harriet said, this is stage 1, and when we look to the UK, who are also doing lots of activities around hubs, they have child and family hubs that extend up to the age of 19 or 25 for those families who have a child with a disability. So there's lots to learn, I suppose, from internationally as well for future steps for our hubs here, and we'll certainly be looking to see with eagerness to see what happens over there.
Yeah, thank you for that. One of the questions we're getting is about, how would you advise someone if they're trying to, get a hub of this kind going in a regional or, more kind of rural area where services are already quite limited, staffing is difficult. I know that you were talking about, the geographical spread, and there's lots of hubs that already exist in Australia. Any kind of thoughts and reflections for those practitioners that are actually based, in more regional areas?
I can start. I think you do need to get together and be a coalition of the willing. You do need some funding. So can you go to your local council? Do they see children and families as a priority? Are these issues, get to know your local member, actually go and talk with them. We are, Susie can talk more to this, we are developing sort of resources for people to, who are thinking about a hub, or how do I go about doing it, etc. We're also looking at a researcher in residence role, which is a model that comes again from the UK, from University College London, where you place a researcher in a hub for, a couple of days a week, for say 18 months, 24 months, and they work with the people on the ground to co-design, implement and evaluate a hub with the view of also passing on that skill set to the people in that hub. So when that research and residence leaves, you've got sustainable, knowledge translation going on. But I think you can't do it by yourself, and you do need some funding, and you do need some good people behind you. Not, ensuring they don't block it, number one, but actually actively supporting it. And I think, we underestimate what our local councils and our local members can do in this space. Susie, I don't know if you...
Well, I think the only thing that I'd add, Harriet, is that community health services are very unique organisations and very progressive in a lot of ways. They've got lots of great relationships with their community and with their local networks as well. So this is a great starting point to really understand what are the local needs, what is the local data telling us around what are the needs of families in this local area. And this is a really great starting point to draw on that data, but also those relationships to help form a coalition, as Harriet was saying, of the willing around how do we develop a hub and what might this look like, and how might we take this through a co-design process. So a lot of those resources will be there and perhaps potentially not require funding, but just a funneling, I suppose, in terms of to the outcomes of a hub. So thinking about who do we already engage with? Who are we linked with? What are your thoughts in terms of what's required? So there's lots of capacity there that we can gather and garner.
Yeah, fantastic. Yeah, so it's kind of getting together the coalition of the willing, sharing the data that you're collecting, mapping out the local needs, and then starting to think about funding options, etc. Be really interested to see those resources as well, Susie. We can share it with the people who've registered when they're available, even if it's a bit down the track. So that's really great to hear. One of the things we've talked about a lot today, and Tess, obviously you presented a lot on, is co-design. I just wanted to tease that out a little bit more, because obviously we've been doing community consultations, for decades and all that kind of stuff. But now we're all talking about co-design. What do you see as the crucial and critical differences? I know you mentioned things, Tess, like that it's iterative, that you keep, keep it alive. You're not just kind of set and, come back at the end and measure. But if you had any other thoughts that you wanted to just share in terms of explaining what co-design really is about and how it's done.
Thanks, Randy. I think for me, I find it really helpful to position co-design on a spectrum. And so we have, if you think about co-design as one form or method of stakeholder engagement. And so as you mentioned before, Randy, you have forms of stakeholder engagement which might be very minimal and, is definitely the way that traditionally things have been done, where it's kind of like, there is a project here, I'm informing you of the project. And then we might move up the spectrum where we kind of have the project team, the researchers, the practitioners, the service, whoever it is, develops most of it and then consults on little bits. Okay, we just wanted to check this with you. How's this working? And then incorporates that feedback and then reiterates. For me, co-design is a step up from that consultation. So it's where you have, in our case, we had some fixed parameters of our project that were based on what we had to apply to for the funding body, what we were applying based on the evidence, what we're applying based on the kind of partner priorities and partner resources. And then we had flexibility within those within our model, because when we're engaging our two key stakeholder groups, so families and our different practitioners, we wanted to make sure that there was going to be enough room for movement for that engagement to be authentic and meaningful. And so it wasn't just a kind of, yeah, we're co-designing, but actually we've designed all of it, and what do you think about it? As you move further and further up that spectrum of participation, you get to really power sharing and decision-making sharing with community and families and practitioners, so that you would have even less and less of that kind of fixed, decided parts. And you have governance mechanisms, which we also had, we didn't go into detail about, where we have the bringing together of all of those different diverse voices across the project, across the levels of the project, all the way from the kind of frontline level, that middle management level that Harriet spoke about, as well as all of the different organisations, making sure that community and family voices are inserted in all of those platforms and respected in all of those platforms is one of the other challenges. It's a different way of working for many people. And so that kind of far end of the spectrum is where you would be completely handing your project over to families and practitioners. What do you want? What does the community want to do? And starting from there. That type of project is much harder to do, largely if the funding is not there, because it's hard to get something funded if you don't know what the project So for anyone out there who's wanting to do that type of work, you might see that as a kind of phase one of your project where you do that needs assessment and get those partnerships in place before you then apply for the grant. But again, that will only be able to be possible if you've got kind of continuing funding streams that would support that type of work.
Fantastic.
And Harriet?
No, all good, Tess.
Yeah, no, that was great. It was a really good description. I've got one question, Harriet, that a few people have asked that you mentioned right in the beginning, which is we know that maltreatment is no worse than bullying, for example, in terms of, impacts on children. And how was that determined? Like, if you could just tell a little bit more about that research or what that actually means, I think it piqued a lot of people's interest.
Yeah, it surprised us. So that was the work led by Professor Tony Jorm, which was a review of all the published papers that they could find, so what we call a systematic review, and trying to look at all the papers that had looked at if you'd experienced these things in childhood, was that having an impact on your mental health as an adult? And it was pulling together, I can't remember exactly how many reviews in the end, but reviews of reviews, so hundreds of papers, and synthesizing that at a sort of analytic level to say what is the impact of those particular adverse childhood experiences on later anxiety, depression and suicidality. I was really quite surprised, and so I think it was Tony and his team, and they went back to that data and really made sure if you scan the QR code and the slides or go to the website, you'll be able to actually read the paper. But I think it's, I mean, of course these things cluster in children, but they tried to tease that out as well. But they've done pretty sound research showing those sorts of things are, really having a similar impact on children's mental health and young people's mental health, and that's got to help us think about where we put our intervention early into prevention efforts. Yeah. I think thank you, the links to those papers.
Yeah, absolutely. And I think, we've been sharing them with the audience. So they're in the chat box for anyone who's interested in looking into those papers more. And yesterday we had, this great presentation from the team that's behind the Australian Child Maltreatment Study that will be released next year. And they're really looking at the prevalence of child maltreatment and impacts on mental health. That's from QUT, being Professor.
Yep.
Yep. Yeah, so we're really excited to see how all of this will map out in the Australian context, because they've got that data, and I think our team have shared a link to that in the chat as well if someone's interested in seeing, and following that research, which will be released around March next year. Susie, one quick question for you, because I know we're getting close to the end, but you mentioned in your policy scoping that you found a supportive policy environment, with many policies focused on adversity. Can you explain this a bit more? Because, having I look around the policy sort of landscape, we often find blocks around adversity being seen in that bigger, sense of housing and income support and other things that impact on families. So when you found that supportive policy environment, can you just explain a little bit more what you did and what you think?
Yeah, of course. So when we looked at policies, we didn't just look in health and we didn't just look in social, but we looked right across the areas of justice, education, social and health areas. And adversity is really quite a broad category. So we actually broke those down into, what actually sits underneath adversity. So we were looking for issues around housing, perhaps domestic violence, abuse, neglect, sexual abuse, a whole range of different elements there, as well as general vulnerability as well. So it was really quite a broad view of adversity. And I guess what we found was that most of those policies were coming out of departments of health at both a state and federal level. And there was lots of intersection between adversities as well. So in particular, there was lots of intersection between abuse, out-of-home care, sexual assault, neglect, housing, financial stress. And I guess that's not surprising, because there is really a good understanding, thankfully, that many of these elements cluster together. But I guess there were other adversities that sat quite separate. So sometimes family violence might sit by itself, or parents with a mental illness might sit out by itself. So generally it was quite positive, but there were areas where we've seen that there could be further work to really bring together some of those adversities to show how they do cluster in families rather than just sit in isolation, and how do we think of a family in a broad sense, or a child in a broad sense, and that being the family. So not just looking at the child and some of the issues that the child might be facing, but of course they're sitting within a family. So considering some of those issues, whether it be parent with a mental illness or incarceration or housing stress or financial stress, and how that actually impacts on the child as well. But there was a lot of policies that intersected with adversity, as I said. So we see this as a positive step in that I guess there's an understanding. There's an understanding, and it's on the agenda from a political perspective. Now it's a matter of harnessing some of that political will, I suppose. And what we're also seeing recently, I think, is that there's an increasing interest in this idea of hubs or integrated care. So bringing together health and social care. So we really need to be able to capitalise on that open door that is there in terms of the policy environment, and see how we might be able to capture that and run with it in a lot of ways. So I'm not sure if that answered your question, Rani, but it is, you know, there's a lot happening, I suppose, and we're seeing lots of changes now with a new government, and we've got elections coming up in November for Victoria and March for New South Wales. So lots of changes, yeah, about to happen as well in those states too, I can imagine.
No, that was a great answer. It is one of the challenges that we do see, though, that there's so many plans and strategies and policies that impact on children, young people and their families, but they're not often quite connected enough. So I hear what you're saying in terms of that supportive environment, in the sense that there are a lot of these issues that are on the agenda and people are starting to pull them out into policies, but how do we help harness that and channel it so that we can coordinate better to kind of get this sort of integrated model more front of mind, rather than let's talk about child mental health over here, about child abuse and neglect over here, domestic violence over here. You know, how do we kind of get that cross linkages happening? So great to hear about, you know, your perspective on that, and perhaps working together more on that, Susie. So I guess just to kind of get to the wrap up stage, I'd like to hear from each of you about what you think might have surprised you most about the evidence review and the co-design work that you've done to date about this project, and perhaps one take home for the audience. Like, what would you like them to reflect on as they go on about their work and take, you know, from your research? Maybe I'll start with you, Harriet.
Thanks, Rani. That's a great question. I think what did surprise me most is what some of the audience have already pulled out, that the different adversities are as impactful as each other. And in terms of what to take home, I think to your workplace, start a conversation. How well are we actually asking about and recognising adversity in the families that we look after and that we serve? Can we do it better? And is there a willingness and an appetite to do it better? Because it all starts with that, I think.
Great, thank you. Susie?
Well, I guess the surprise for me is that, you know, there's lots of hubs that are already out there across Australia, and, you know, they're going about their work on their own. And I guess some of the work of the National Child and Family Hubs Network is really about how do we gather and harness some of this energy and create not 1,000 flowers blooming across Australia, but perhaps a little more of a coordinated approach, and be able to use that for advocacy and broader support. So I think my take home would be, if there are hubs out there, or perhaps on this webinar today, if they'd like to reach out, I'd love to know where they are and what they're doing. So I'd love to hear about them and be able to use that for further communication, so to be able to keep in contact with those hubs. So love to hear from them.
And my take home's pretty my surprise is contextual, in the sense that the Wyndham community have been so incredibly embracing of this project. And for anyone who's ever done any service design or research before, often you're kind of trying to entice your people to talk to you. But really, we had a lot of people knocking on our door being like, yes, so happy for this to be happening in Wyndham. How can I take part, both from a family perspective and practitioners and services? I think my key take home from a co-design perspective is really that sometimes there's a bit of fear or skepticism about bringing together family members and practitioners or services into the same space. Sometimes there's a fear of the potential risks that can happen and that separated processes. But I would really urge anyone in the audience to get rid of those boundaries, put people together in a safe, facilitated space with really clear kind of agreements of how to work together, and you'll have some really magical things happen. So thank you.
Fantastic. And can I just ask Tess, all of you, when is the next bit of the evaluation going to be done? When would the next results be, or when can we hear about how things are going?
We are currently writing the baseline paper, which will report in more detail around the kind of what the picture at the start of our project was. At 6 months space, the 6 month data collection is happening in September and 12 months in March, April next year. So we'll have some preliminary results in March, April, and unfortunately the publication process can take a lot longer than that. But would be happy to talk publicly about the results, probably not in written form at that point.
Okay, fantastic. So everyone just watch the website, and in that sort of period, there should be more information. So thank you all. That was a really great discussion. I think, the audience got a lot out of it as well. I know I learned a lot more about co-design as well. Thank you. And I just wanted to reiterate to the audience and to yourselves, this is not the end of the conversation. We'd like to keep working together, keep sharing this sort of information. And I hope that the audience will take some of what they've learnt together today forward in their work. And as Harriet said, start a conversation. Let's keep, the dialogue open and see what we can do. For the audience, as this webinar finishes, there'll be a short survey that'll pop up. Please do take the time to give us some feedback. This is great for NAPCAN and the presenters. We want to know what you enjoyed and what you want to find out more about. But also, just before we end, we will like to share a short video with you. This is really about the voices of children. It's beautiful. It's a compilation of artworks that children have shared with NAPCAN in this campaign as a part of telling us what they value in their community, what makes them feel safe and supported. And we know it's so important to hear from children and young people themselves, as was demonstrated in the conversation today. So please do stay on and watch the video. Trust me, it's worth it. And thanks so much for joining us today. Thank you.